informational webinar for ATRT, the second of 3 disease-specific brain tumour webinars in May to coincide with Brain Tumour Awareness Month. I'm Bruce Campbell.
And I'm Alan Campbell, and we co-founded PNOC Foundation in 2013, 3 years after our son was diagnosed with a brain tumor.
Thank you to viewers for joining us from both near and far. Today you'll be hearing from our well-renowned PNOC doctors specialising in ATRT, pediatric brain cancer, about the disease, the current state of research and clinical trials. These doctors are dedicated to changing the outcomes of this specific childhood brain cancer, and fortunately for us, get up every day thinking about changing this disease.
And you'll also meet some very special patient families and hear their stories and insight. The purpose of today is really information sharing, so we encourage you to post your questions in the chat for all the panelists.
For those of you joining us for the first time, the Pacific Pediatric Neuro-Oncology Consortium, or PNOC, is a leading global pediatric cancer consortium with study sites within the US, Canada, Europe, Australia, and Israel, striving to improve outcomes through a unique collaborative approach, translating the latest findings in brain tumor biology into clinical trials and more effective treatments. A key mechanism to support the translational research is through the unique PNOC working groups, which include investigators from around the world with specific tumor type expertise and focus. Through scientific collaboration and consensus decisions, the most promising clinical trials are developed. Advocacy and philanthropic groups are invited to lend perspective and partnership.
And PNOC Foundation, kind of separate to the scientific consortium, is really created to lead the fundraising, the awareness, and the support for the PNOC Scientific Consortia so they could do what they do best.
Without further ado, it's a great honor to introduce today's distinguished panel. Dr. Savine Mueller, PNOC project leader, co-founder, and assistant professor of clinical neurology at UCSF. Dr. Ashley Margol, co-chair, PNOC ATRT Working Group Director, Neuro-Oncology Program, Children's Hospital, Los Angeles, Associate Professor, Keck School of Medicine, University of Southern California, and Dr. Alyssa Reddy, Professor, Child Neurology and Neuro-Oncology, UCSF and Benioff Children's Hospital, Director, UCSF Neurofibromatosis Program.
Did that well. We also have Dr. Eric Raabe, Associate Professor of Pediatric Oncology, Instructor of Pathology, Johns Hopkins University School of Medicine, and Dr. Shannon Lundy, Associate Clinical Professor, Department of Pediatrics, Pediatric Neurocognitive Psychologist at UCSF. And we also are honored to introduce a special patient family guest. Let's see, we've got Kate and Matt joining from California, parents of son Frankie, who's just adorable, diagnosed with ATRT, and Robert Wilkerson, who I've just met, also joining from California, father of daughter Kinsley, who was diagnosed also with ATRT. And last but not least, we also have Rachel Cassells, our PNOC Foundation team member, and she's going to be helping us with some of the moderating.
So, first question I think we'll throw over to Dr. Reddy. And it's a general question, Dr. Reddy. You know, what was the state of this disease 10 years ago? And what's the state of the disease right now?
Yes, thank you. Thank you very much, Bruce, for asking that. And what we've done as a group is we've put together just sort of a short presentation, if that's okay with the group, to kind of talk about the history of the disease and where we've come in the last 2 decades. So if that would be okay, I'm going to do that presentation.
Absolutely.
May I ask, are my slides showing?
Yes, yeah.
Okay, let me just bring up. Okay, great. So first of all, I want to start by saying good morning to everyone and welcome to this symposium. Thank you so much to Alan and Bruce and PNOC for putting this on behalf of our ATRT working group, which is not only the people here, but there are several other physicians and researchers involved. We want to say thank you to PNOC for allowing this, and to the sponsors, and of course to the families, because the patients are the reason that we're all here. And we really do this as a partnership together in trying to solve what is a very a very challenging and difficult tumor to treat. So I'm hoping my first blue slide shows up. I just want to give a quick history. The first report of ATRT was actually in the late 80s. It was reported by a group at CHOP. The original name of it was called the Atypical Teratoid Tumor of Infancy. And this was noted by 3 people, in particular, this neuropathologist named Lucy Rourke at CHOP. And Dr. Rourke was really instrumental in a lot of the early work done in pediatric brain tumors, and that's because she reviewed many, many cases. So as you know, as a kind of community, these tumors are rare at individual hospitals, but when we put all our patients together, we really were able to do more and understand more. So Dr. Rourke was at CHOP, and she was reviewing many, many cases through the Children's Cancer Group, and she recognized that there was a subset of these tumors that were thought to be medulloblastoma or other embryonal tumors that looked a little bit different. At the time, she worked with 2 other people, Dr. Packer, who's a very well-known neuro-oncologist and who I had the real honor of training with many years ago. And he clinically took care of these patients. And then Dr. Beagle, who made a major contribution in recognizing that these tumors have a unique genetic mutation, initially called the INI1 gene. So like anything in medicine, you want more than one group to prove that this does exist. And so another very well-known neuropathologist, Dr. Peter Berger at Johns Hopkins, also identified this. And just as a historical note, many years ago, this is how we used to get articles. We had to get them from the library. You can see this was stamped, but this was an article that I had gotten that Dr. Berger also wrote in the late 80s. And so we understand that this disease wasn't really recognized until 1993 was when it got the official diagnosis. We know that ATRT occurs both in what we call the infratentorial part of the brain, or the lower part of the brain, and the top part of the brain, or supratentorial component. It has areas under the microscope that look a lot like other primitive neuroectodermal tumors, but there are areas that are different, and that's what sets ATRT apart. What was a real advance in this tumor, because when it was first diagnosed, people would have to send cases to Philadelphia or to Baltimore for one of these real experts to look at it. But once the gene was recognized, which initially again was called INI1, but later renamed SMART-B1, they were able to make a stain that could tell us whether or not the tumor was in fact an ATRT. And this was a real advance because this became readily available. And this is how pathologists make the diagnosis today. So my role in this started back in about the year 2000. This was a time when the 2 cooperative groups in the country came together to form the Children's Oncology Group. And this is what we knew at the time about this. So this is obviously, over 20 years ago. But we knew that the early reports showed that almost no patients survived ATRT. And in fact, when we looked at patients on the prior cooperative group trials, which at the time were the Children's Cancer Group and the Pediatric Oncology Group, with what we would call standard therapies, there were really no survivors, or very few survivors. So we took a deep dive on case reports, and there was a registry at the time to try to figure out, who were the patients that survived, and could we come up with a protocol that we could do across institutions to try to treat patients with ATRT and improve survival. So that was a very long journey, and much longer than any of us would like, but these, it is a process, and we had to go through a lot of approvals, but we did run a study, and I think many of you are aware of this study. This was run through the Children's Oncology Group. It has a long name. The short name is ACNSO 333. And basically this trial took what we knew about patients that survived and tried to give sort of the best, our best, what we thought would be the best treatment. It was based on a prior trial that had been done in young patients in CCG called 99703. So some of you may have heard that. So this was similar, but it had a couple of differences. So basically what the study did, and some of you, your children have either or may have even been on this study or have been treated according to, is we did require that people submitted tumor tissue. And this was actually this was the first children's oncology group study that actually did that. And it was so important for helping us learn about the disease. So basically, as a lot of you know, and I'm not going to go into a lot of detail, but this protocol gave 2 cycles of very intensive chemotherapy. And then patients either went on, it wasn't a randomized, but depending on their extent of disease and the location of their tumor and their age, they either went on to get focal radiation or they got high dose chemotherapy. And then whatever they hadn't gotten, they got at the end. We believed when we wrote the protocol that the earlier we gave radiation, the better the chances patients had to survive. And that was based on all the sort of initial data we had available. So this is the outcome for this study. And this there are 2 lines here. The blue line is a measure of overall survival, meaning how long the children lived after diagnosis and starting the treatment. And the red line is what's called event-free survival. Now, event means either the tumor came back or something else happened to the patient. And so these are the lines that show us the survival of the patients. And of course, so at 24 months, which is the 2-year mark, so this was our early, or what we would consider one of our early measures, the overall survival of the 65 patients who we had adequate data to do the analysis on was slightly over half of the patients. Our control group were the patients that were treated on previous, what we call infant brain tumor chemo studies. So these did not have radiation and they did not have high dose therapy. And what we found is that the children treated, the young children less than 3 years of age did have improved survival. So you can see from a statistical standpoint, this was significant. And we certainly had, this is event-free survival. So we certainly improved that, but we all recognize that we have much more work to do, right? We want this curve ideally to be up here. But certainly we made an improvement with these intensive therapies. Now, I think it's important to point out that although ACNS 333 was run through the Children's Oncology Group, there are other protocols that have shown sort of similar outcome results. So there is a protocol, and again, some of your children may have been on this study or treated according to the Dana-Farber protocol, run by Dr. Chi, who is part of our working group, but unfortunately couldn't be here today. And this protocol takes a slightly different approach. It uses intrathecal chemotherapy and radiation, as well as intensive chemotherapy, but not transplant. European groups have also run a similar study. That's a registry study, so it doesn't clearly dictate the type of treatment, but again, had similar outcomes. And then others have done analysis where they kind of combine patients. And it really looks like high dose therapy and radiation are at least associated with an increased chance of surviving TRT. Another protocol that is popular and has been shown to have some effectiveness is the MEMET protocol that Dr. Slavik started and runs in Austria. So one of the things that we try to do with ACNS 333, and I know is really important to us as clinicians and of course to families, is to try to figure out who are the patients that do well and who are the ones that relapse early. So we've looked at all of these things from our cohorts. So the age of the patient, the location, whether there was spread of disease, how much was taken out, if the patient had a germline mutation, an order of therapy, as well as the molecular subtype. And I want to tell you that the study was not what we would call powered, so it wasn't really designed to answer these questions. So more work will need to be done. But I did want to just show you a couple of things, and these were things that we recently looked at, because these are This is called a cumulative incidence. So this is how many people at a given time point had relapse of their disease. And I just want to point out a few things. This is actually from a talk that I'm going to be presenting next month. But one of the things that I think is important to know is in our cohort, we don't see a difference in patients who had just localized disease versus those that have metastatic disease or spread of their tumor at diagnosis. Another thing that we feel is really important in our study is once patients got past induction, there was no difference in the chances of relapse, whether they had radiation first or they had the high-dose therapy first. And this was an important consideration for us because some of the side effects we saw from radiation were more prevalent in the group that got the radiation first. So these things are negative, but I think they are negative in terms of what we would call a p-value, but they are important. Another really important development in ATRT, which I know a lot of families are aware of, and this is something that Dr. Annie Wong and colleagues, as well as a group in Germany, have discovered, is when they do methylation profiling, they've been able to identify 3 subgroups of ATRT. So what Dr. Wang was able to do is look at a historical cohort, meaning these patients weren't necessarily treated the same way, but they did come up with what's called a consensus between the group at Sick Kids in Toronto, where Dr. Wang is, and the group in Germany of 3 subtypes. And again, this is important because 2 different groups had essentially the same findings. So these subgroups are called the TYR, the sonic hedgehog, and the MIC. And we have some ideas about these, but we're still learning quite a bit. So again, this is cumulative incidence of relapse from the 333 cohort where Dr. Wong did do put all of these patients' tumor samples into her classifier. And we do see some interesting trends. So we know that patients with sonic hedgehog, again, this is from our trial, it's not, the data is a relatively small subset, but we know that none of the patients with the sonic hedgehog subtype had relapse in the first 6 months. They did have relapses, so certainly these patients still do have relapses, but you can see here, this is their rate of relapse, and it is below both the TYR and more importantly, the MIC. So again, from our study, it looks like the patients with the MIC have the highest incidence of relapse. So obviously this is really important information, but we need to combine this information with other studies. And I think I'll stop there. I was just going to mention one more thing because I know it's of interest to people and I know it's some of the questions. And this is outside of the subgroup space, but we know that the SMART-P1 gene is part of something called the Schweiss-Smith complex, which is involved in something very, very complicated called chromatin remodeling. But we do know, and this is really simplifying a lot of very eloquent scientific work, but we know that this mutation is associated with not only ATRT, but a variety of cancers. And so one of the things that we're really excited about is the role of EZH2 inhibitors in treating all ATRT, not subgroup specific. And that led to a trial that is recently completed using the EZH2 inhibitor tazemetostat. And I know we have some questions about that, so we're happy to talk more. But that's the end of my presentation. So I appreciate everyone's attention, and I hope this information is helpful to the rest of our discussion today.
Dr. Reddy, thank you so much. Yeah, we might take a pause there and take a couple of the questions from the chat.
So you want to, maybe Rachel want to pull one up? Or Rachel, maybe I'll take the first one then. Let's see. Gosh, we have a couple good ones coming in. Our daughter completed the ACNS 0333 in March. then had 6 weeks of radiation. What are some of the current thoughts on maintenance after completion of this specific protocol? And then thoughts also on this particular drug, tazemetostat, as a maintenance. I don't know who would be best on the panelists to answer that, but if someone could answer that, that would be much appreciated for one of our joiners, one of our viewers.
Ashley, do you want me to take that one?
Sure, go ahead.
Yeah, like I said, we're very excited about tazemetostat. There have been case series that report response. We don't have the results yet of the phase 2 study, but we are working on a new trial that uses essentially the 333 treatment protocol and does add in tazemetostat. So that is a trial that's being done, and I think it is a drug that's showing promise. That study will include a maintenance with it, so I think we're getting a little bit ahead of ourselves to clearly recommend it, but it is something that patients are taking, and it is commercially available now, not for this indication, but for another tumor that has the mutation.
Okay, here's another one. This is for the entire panel. It seems that there's been a lot of talk about the 3 subtypes for a while, and every hospital is having success with different subtypes. The data seems to be conflicting and very frustrating. When can families expect targeted therapies for each of the subtypes?
I can take that one. So we feel your frustration. We feel actually quite similarly. I think that's something that's unique about this disease is that it's very rare. And as Dr. Reddy just pointed out, I mean, that was a study that took a very long time to complete, and there were 65 patients enrolled. And so when we as a group in PNOC have sat down and discussed issues like this, these same frustrations come up for us, which is there are data that are conflicting, and what data can we trust? And so because we feel the same way, we're really trying to figure out a way to kind of capture all patients with ATRT moving forward, so that we can actually have a large data set, a prospective data set that we can interrogate, and we can figure out more about these molecular subtypes. So I don't have a good answer for you about when, although I will say I think it's definitely coming. There have been some preclinical papers coming about looking at different subtypes specifically, and it kind of I think goes into another question about immunotherapy and whether or not there's going to be immunotherapy options for subsets of patients, including molecular subgroups of patients. So when can we expect targeted therapies for subtypes? I don't know. We might end up with something like Dr. Reddy was talking about, tazemetostat, which is good for all subtypes, and then trying to really hammer down. And that's what Dr. Raabe and some of his colleagues on the basic science side are really trying to do, is say, are there molecular therapies that are going to work for all subtypes, or are there different molecular therapies that are going to work for, the mixed subgroup, for example? So when, I would say I hope soon, but I think we have a lot to learn still about this disease, but I'm very hopeful. Dr. Raabe, I don't know if you want to comment any more from the preclinical side of things.
Yeah, that's great. Yeah, thank you. And thanks for that question. I think a lot of what we do in our group is trying to find exactly those therapies that could work on molecularly targeted fashion in subgroups, like the mixed subgroup, for example. And so, part of the bottleneck is actually finding drugs that get into the brain that are tolerated by very young children. So, we're moving in that direction. And I have one slide that hopefully we have time, I'll be able to share with you, sort of highlighting that there's, potential vulnerabilities, especially in the mixed subgroup, that we might be able to target.
I have a really question I'm hoping I could just throw in there. When our daughter was originally diagnosed, the pathology report didn't involve any subtyping. And I know this is 2018, so it's a newer thing. But later on, we got methylation. Is subtyping part of ATRT pathology now, like the initial pathology? And if not, why not?
So it does take methylation profiling to get the subtype, and there are only a few places that sort of have what's called CLIA certification to do that. So you have to not only be able to do it as a research tool, but in order to report it out to something that a patient family can have, you have to, the lab has to be certified. So right now, at least we, as you know, we send our cases to the NIH, to Dr. Raabe, who's been very gracious and does this at no cost, actually, and sends back a very nice report, which is what we received. UCSF is working on getting CLIA certification to do this, not just for ATRTs, but other tumors. And there are a few other places, I think, that do it, and they do it in some European sites as well. But it's just, it is relatively new technology. So again, I know that's a frustration, and a frustration for all of us. But this is, again, this is what just a few years since the whole subgroup methylation work has been published and out there.
We've got another question. Carolyn asks, I'm very interested in what the doctors think of Bionaut. The company is located in Los Angeles and has started the TRAILS program. I feel that this company could be a game changer in applying the medicine directly to the dust-sized tumors. And the company says it is not an invasive way of treating the tumors. Is anybody in the panel familiar with Bionaut?
I'm in Los Angeles and I'm not, but I Googled them. And I think it's really interesting just from the little bit I've seen, but I haven't spoken to them at all. I'm not aware of what they're doing. I don't know if anybody else is. We'd be happy to talk to them though. It sounds like they've got some interesting stuff, but
yeah, I'm not aware of anything. Yeah.
I'd say just keep in mind some of the bottlenecks for new clinical drug development are that things have to be tested in adults first to be shown that they're safe before they can make it into children. And the enthusiasm, unfortunately, of many drug companies for testing a drug in an infant is very, very low because the risks are very, very high. And the rewards, especially for a tumor like ATRT, where there's so few patients, are very low. So there may be promising therapies, but first they have to work and find a home in an adult cancer frequently. And then people like us on the call try to contact drug companies and get those drugs and try them in our models. But that's sort of part of one of the frustrations of being a pediatric oncologist in general. And some of the ways that things like the PNOC Foundation can help is by funding those preclinical studies, which drug companies themselves are not going to generally do.
Right. Yeah, I think it's important for the audience to understand that many of the drug companies, to your point, Dr. Raabe, they don't want a negative outcome in a pediatric case. So they're reticent to actually even make those drugs available to pediatrics.
Yeah. So there are a few good questions from the audience. So Alyssa, one was for you. I think when you presented the data, one family had the question where your timelines from initial diagnosis or after treatment. And then Ashley, if you maybe would want to comment, there's a question about the use of photon versus proton radiation therapy. And then the third question maybe to Eric, really the risk of siblings in this disease. I think these are very important questions for everyone maybe to answer. So thank you.
Okay, so yeah, so the timeline is from when the patients were, when their diagnosis was made, right? So it is when their initial diagnosis was made. So typically when you enroll a patient on a trial, you have to put in the sort of date of diagnosis, and it's typically the date of the surgical resection, because that's the date that's on the pathology report. So that data though reflects patients from their initial diagnosis.
And then Sabine, was it just about which is better, protons versus photons? Okay.
Just a general comment on that. Yeah.
Sure. So I know there's going to be some up and coming radiation therapy data coming out of the ACNS 0333, but in general, we don't have data saying which is more effective, protons versus photons for this particular disease. There was some data that has come out more recently in the medulloblastoma space, which is different because those patients get craniospinal radiation. But that was, discussing cognitive outcomes when comparing protons to photons. So most of these patients, patients with ATRT who are getting radiation tend to get focal radiation therapy. And so whether or not there's going to be different neurocognitive outcomes with the use of protons versus photons is probably going to depend a lot on the location of the tumor and the size of the tumor. So I think it's going to be really specific to each individual case.
And I can just comment on that too, just generally in brain tumors. I think there's a hope that protons will potentially and photons will be a little bit better, but the literature is still fairly mixed, and there's just still the longitudinal data is not there yet for us to really, I think, very strongly say one is better than the other at this point. We're certainly trying to figure that out, but I don't think we really know that yet.
I think
you go ahead.
The last question was related to, I'm sorry, go ahead, Mr. Campbell. Do you want to?
No, go ahead, Dr. Raabe.
Yeah, so the last question I think was related to sibling risk of when you have ATRT. So it's pretty standard for any infant or any child with diagnosis of ATRT to refer them to genetic counseling because there is a risk that they themselves have a germline mutation. That means an alteration in every cell in their body that puts them at risk of getting another sort of INI1 mutant tumor later in life. Could be another ATRT or something else. So that's the place to start. And if the child, him or herself, does not have a germline alteration, then the risk of this happening in another child is vanishingly small. So it's really not going to happen. So,
right. If they do have a germline mutation, right, which we know can happen, and I think this patient family might have, right, we do recommend that the parents go to genetic counseling and get tested. A high percentage of even the germline mutations are what we call a spontaneous mutation, meaning that it wasn't inherited, it just happened in that particular individual. But if your child does have a germline mutation, then you should talk with a genetic counselor with expertise in cancer genetics and consider whether you want to be tested yourselves. If you're a carrier, or if you have the mutation, right, then you could also consider having your other children tested.
These are all really good questions. We wanted to also bring Kate and Matt in because they've certainly walked this particular journey, and be great to hear a little bit about that particular path and share any advice to other patient families that are dialing in.
Right. I'm Kate. This is Matt. We have a son, Frankie, who was diagnosed in 2016. That was 5 years ago, like next week, actually. So we're almost 5 years out from his surgery. So he had a 9-hour surgery and had his tumor removed completely, I guess a full resection. And then we went through the ACNS 0333. It's hard for me to remember that. And he was kind of a model patient for that. And we really didn't have a whole lot of hiccups in it. So we consider ourselves really lucky with that. But yeah, we went down to UCSF for a year and back and forth a little bit, but mostly we stayed down there and we felt like we got great care. And obviously it was really, really hard. But he responded really well and he's still here. Makes me choke up, but we're really thankful for what all of you doctors have done over the past years. We have a daughter who's a lot older, and just the thought of her getting this when she was young, it's horrible that in the past these kids haven't been able to be treated, and I'm just so thankful that Frankie was able to be treated and has very few I don't know what you would call them, side effects, not side effects, but he's doing great. He's going to school, he's playing baseball, and yeah, we're very thankful. But we also needed to address like our advice to new parents who are newly diagnosed. And I think Matt can eloquently speak on that.
I don't know. When the I think one of the biggest lessons we learned from our experience, and my advice to other parents, is we figured out, I mean, from that first, he had a seizure, so we went to the ER, and we figured out very quickly that whatever process or stress or anxiety or grieving, we tried to keep it away from Frankie. At his age, he was 3 at the time. And we realized that whatever he was going to experience, the way that he was going to kind of take this in was going through the lens of like how we took it in. And so we just tried to keep just everything kind of shielded from him, as difficult as it was. So we'd take shifts, get it out in the hallway, come back in, and we always tried to keep like positivity and optimism. And in a weird way, it kind of like reverse engineered itself. He was just always happy. He actually looked forward to going to the hospital and was excited about it. And that took the stress off us. And so it created like this feedback loop where the hospital was always like a positive experience. And I felt that that was like a huge kind of tool in our arsenal.
I would say that it's important for parents to take care of themselves and to eat right and to continue to walk. I'm sure, Robert, you know what I'm talking about. You have to take care of yourself or you can't take care of your child. You need to keep your chin up and deal with it. Unfortunately, that's just kind of how it is.
Yeah, it's going into it, it's like this, you're kind of hit by a train and you kind of come away from it sort of like, okay, maybe I can handle this. And it ends up being definitely harder for longer than I guess what I expected. And yeah, it's at some point you start to realize like, yeah, if I don't sort of address some sort of my needs, like I'm not going to last. I'm not going to make it to the end of this marathon. So yeah, I completely agree.
As far as like the clinical side of it, I think that if I were to be asked by a parent what they should do about, you know, what protocol, and I would say, you know, there's several opinions out there about how to treat ATRT, but to get a second opinion if you need it, and or if you feel like you need it. We felt very comfortable with, we were given 2 options, and honestly, we trusted our doctors so much that we told them to pick it. We were like, you do the research, this is your expertise. But you know, I'm just so thankful that all the hospitals and doctors have been talking to each other, and it gives me a lot of comfort to know that, you know, if God forbid Frankie ever got cancer again, that there's this group of brains together coming up with really great ideas.
Thank you, Kate. I wanted to just circle back to some of the questions that we have. We have a lot coming through. Dr. Reddy, perhaps this is for you. In your presentation, you mentioned subtypes, and we have a question about how can you get your child's subtype? Is that something, what is that process exactly?
Yeah, so again, it's right now, today, you know, if someone wants to do that, what they should do is talk with their primary oncologist, let them know that it can be done at the NIH. And if their oncologist has any questions about where to send it, it's done by a doctor named Dr. Ken Aldape, and we can send out that name, but we could also give them the contact information. But as of right now, he's very gracious in doing that. And again, there may be other places if they send it, they could ask it be sent for methylation profiling. That's. But again, I want to. I think it is. I always tell families, I think, you know, information is power, and even though we might not know today exactly what that means for your child or how to treat them, it's good information to have. But we are not, at the current time, making treatment recommendations based on subtype. We're trying to learn as much as we can about the unique characteristics of each patient. I would say that's where we're at right now.
Great, thank you. We have a question about the causes of pediatric brain tumors in general, and I think this is really important because I hear it from a lot of patient families. What should we do at home after the treatment is done?
As far as, yeah, this actually might be better answered by our parent panel, because from the medical side of things, you know, we don't really know. We know, you know, like Dr. Raabe and Dr. Reddy were saying that some of these, you know, some of ATRTs and some of other pediatric brain cancers do have an underlying genetic reason. The patients might have a germline mutation, and most of those patients are being captured, and then those patients will have screening protocols. So for patients that we know have an underlying what we call cancer predisposition syndrome, we'll continue to screen them really closely for the development of other cancers. But for children who don't do that, there's really, when you're done with treatment, I don't know, parents, do you have any suggestions? Because from the medical side of things, it's
I think so. Go ahead, Kate, and then I wanted to add something to that too.
When Frankie was done with his treatment, we had been in sort of go mode the whole time. And when it was finished, it was sort of like, we were like, wait, there's gotta be more. Like we need to make sure that this doesn't come back. And we were really motivated to, like, you know, we were still on this forward path of dealing with his cancer. But
I had experienced that from, I don't know, or like a psychological component to this, is that we were so immersed in the process of his treatment. It's all we did. It's all we thought about. And I had just personally, it wasn't until we got back to our real life, you know, moved back into our house, you know, went back to work. And it was just, that's when the stress hit me, because it's like I had just never stopped. You know, we didn't have time to think about it. We were fighting a fight the whole time. And getting back to real life was vastly more difficult than I anticipated. Absolutely.
Thank you for sharing that, Kate and Matt. And I think that, you know, from a personal standpoint, that reintegration after treatment is such a big, you know, component to the whole child. And I think this is a question really for Dr. Shannon Lundy, because certainly for our son, when we went from the great care of all the medical team like you, there's a lot to try and deal with in getting back to school, or just back to all of the community and activities, sports, and you know, Dr. Lundy's work getting all of the baseline as well as checkups with the neurocognitives was just profound. So Dr. Lundy, do you want to add some thoughts to that about that question? I thought that would be well suited for you.
Yeah, of course. I mean, it is, I think, just what Kat and Matt said, as well as what Alan and Bruce have been through. I know both of their children. I have the privilege of knowing both of their children really well. And I do think that all family systems handle these situations in different ways and have, you know, the different ways in which they cope. And I think that along the way, figuring out what it is your family that is going to work and isn't going to work is really important, and taking care of yourself is really important, and reaching out to the medical team if it's not going well, and if you need support, so that you can talk to somebody if you need to. It's absolutely reasonable. But I think there's many, you know, for these, especially this patient population, we do want to watch them very closely from a developmental perspective, because due to all their treatment, they are at risk for cognitive issues. And we want to make sure that they are well supported going back once they are able to start school. There are lots of interventions that can be done from an early intervention perspective for kiddos who are under the age of 5. And then once they start school, there are lots of different ways that we can support them in the academic setting so that they can have success. And so I think having evaluations can be really, really helpful and meaningful. I also think that piece in terms of just overall emotional behavioral adjustment and social adjustment has to be discussed, because it's hard when you're in treatment for such a long period of time. Kiddos are missing out on really important periods of social development just because they're isolated due to treatment. And so making sure they have opportunities to slowly reintegrate in a positive, meaningful way with their peers, both at school, but also in their community, and doing things that make them happy are really important, and not taking on too much. And I think too, for kiddos who've had a lot of stress and are having a hard time processing everything, being able to talk to somebody and connect with somebody about everything that they've been through is really important. And so all of those things kind of come after treatment. But if you need those things, I think at most places know that you have a team, a multidisciplinary team from a neuro-oncology perspective of clinical psychologists and social workers and neuropsychologists that are there to help support you along the way for the long term and for the journey that lies ahead. And I think making sure you're connected to those different resources and specialists is really important.
Thank you, Dr.
Yeah,
Lundy.
yeah, that was awesome. I just add to that, Dr. Lundy, that I think that, you know, rightfully everybody's focus, parents and clinicians, is in the early stages of diagnosis is on survival. You know, everyone's so focused on that, and rightfully so. And then if you're fortunate enough that your child gets through that initial battle, then there is this whole other layer that you're not even contemplating at that point. And it is all of this cognitive and social and emotional aspects that tie back to the cognitive development. And I think for us, and, you know, I give full credit to my wife, you know, really being an advocate for our son and getting him that early detection with you, Dr. Lundy, and then putting the scaffolding around him so that he could actually be really successful and learn how to actually learn around the subtle deficits that he had, you know, have led, fortunately, you know, for us to a really, really great outcome. And but without that scaffolding and intervention, you know, it's very likely that he would have had a lot of cognitive issues, and that would have led to self-esteem issues that would have affected his social and emotional well-being. So I think those things are very subtle compared to like surviving a brain tumor. But in survival, they do become really important in terms of the whole health of the child long-term.
Thanks, Bruce. We have a question about 8H9 immunotherapy. The doctors are saying this could be a game changer and has been for neuroblastoma. The person who's asking it has a relapsed child who's 4 years old and has gone through MEMET and second radiation. But if somebody from the panel could share their thoughts on 8H9 immunotherapy.
So 8H9 is an anti-GD2 antibody, and it's been really successful for and its counterpart. So there's a similar antibody, dinutuximab, which is also an anti-GD2 antibody, and those are really helpful against neuroblastoma because neuroblastoma expresses GD2. And this study, I believe, are they referring to the one that's at Memorial Sloan Kettering? There's a radio-labeled 8H9 study that's being conducted at Memorial Sloan Kettering. So they actually attach a radio-labeled tag to it and then inject it into the ventricle. And then it's really to help deliver not only the antibody, but essentially like the local radiation therapy with the radio-labeled antibody. So they're testing it right now in medulloblastoma and some ATRT patients. I think we have to wait and see what those results are. I know there's a push to open it at other sites through the PBTC, mostly for medulloblastoma patients. But I think this is a good example of kind of how the field is moving forward. And so now we're starting to see more innovative therapies. There's other immunotherapy protocols out there. So the Seattle group has a CAR T cell against B7H3, and we know that B7H3 is expressed on ATRT cells. So I think that's a really interesting trial as well. Again, we're going to have to wait and see the results of these studies, but it's really great to see that we've got these newer, more innovative therapies that are coming out, and that ATRT patients are included on these trials, which I think is a big deal, because if you look back historically, ATRT patients, because the disease is so rare, oftentimes weren't included in studies. So I think we're starting to see these, newer studies coming out, and we're really looking forward to those results. But stuff like this, 8H9, these B7H3 CARs, I think are going to give us a lot more information, but we'll have to wait and see.
Thank you for sharing that too. I would like to go to Robert, because I think that, certainly with his daughter Kinsley, he's got a lot of experience going through their particular journey. And you've got the experience also of relapse and thoughts on treatment. So Robert, would like to really hear a little bit about your journey and where you're at right now.
Yeah, sure. It's interesting to hear these questions, and I feel like they relate to our path on all these different levels. So September 2018, actually our daughter's having fairly vague symptoms. My wife is a physician assistant, and she was seeing things I didn't. But fast forward a couple of weeks, and a CT did reveal 6-centimeter frontal lobe tumor. We did have a gross total resection within 48 hours. And at that time, success in the sense that, they were able to, get everything according to the surgeon. But pathology came back, ATRT, a few weeks later, and then it was sort of, okay, what do we do from here? We were lucky enough to connect with Dr. Reddy before pathology results came back. So I was very serendipitous. And so obviously ACNS 0333, we talked about that with her. We knew we had to make a decision quickly. We did consult with St. Jude's. The SJ-ATRT trial was something that we would have access to. And Stanford, actually, we're in Northern California, Stanford, offered that to us. We did sort of go down there and had this whirlwind journey of talking to, a couple institutions, but in the end, it just made sense to go with Dr. Reddy, and we trusted her. And so October 2018 through spring of 2019, we had a very, I would say, complicated path through ACNS, but got through the induction chemo and 2 of the stem cell transplants before it became clear that her body just probably wasn't going to handle any more chemo. So we went to Boston, Mass General for focal radiation, proton, which, in the decision-making process for us, we could have done photon at UCSF. It would have been easier life for us, but, weighing the sort of side effects, the guidance we got is that proton was the way to go, just more targeted. So we landed at Mass General with Dr. Yock. It was actually a great experience. My daughter handled it well. Kinsley did great. And we came away with this sort of eye of the storm. We felt like we were done with ACNS. We asked questions about maintenance, but, there was no sort of protocol beyond that. And so, quite honestly, we did our best to enjoy life. For the question of what to do after treatment's done, enjoy every day. So we had a good sort of eye of that storm. And then January 2020, some cells were detected in her lower spine. So it was a full brain and spine MRI. And so drop metastases were detected. At that point in time, the recommendation was CSI, going back to Mass General and doing, full brain and spine. That was tough to swallow. Our daughter's, she's had no deficits, and it was just felt like, okay, are we, and so we did some research, and I'll say the information that's coming out of this is amazing. You guys need to keep doing this, because thinking back, having sort of even just that presentation Dr. Reddy gave at the beginning would give us a better sense of sort of the path ahead. But it sort of felt like, okay, we're members of a Facebook group that I imagine a lot of the people on this are also members of. And quite honestly, scouring just those conversations led us to, what are the different options that, I think we were in denial of the CSI, but we did find that MEMMAT she responded well to it. Dr. Reddy, recommended sort of this modified version of it that, fit well into our lives. We had good quality of life. Every 2 weeks, we had to come back to UCSF for intrathecal, but she handled the meds well. And it was, it was a nice spring. And then summer 2020, so last summer, she had detected leptomeningeal spread to the posterior fossa. So we knew at that moment CSI. And so we rushed off back to Boston and did full brain and spine radiation at Mass General, and followed that up with tazemetostat. That was generally recommended by the team at Mass General. We consulted with Dr. Chi. at Dana-Farber, Dr. Reddy sort of agreed that this is, there's a few options out there, but tazemetostat seems to have, sort of one of the better response profiles. And we were lucky actually enough that the FDA approved a tazemetostat for adult cancers while we've been in treatment. So, because early on, we heard of tazemetostat, but it was actually very hard to become part of those trials. And so kids were just not getting access. And so Dr. Reddy and our team worked hard to get us sort of access to actually an off-label use of tazemetostat. So we had to teach, she's now 6, but Kinsley basically swallows 7 200 milligram pills a day. And it's kind of amazing. We've been told to do YouTube videos on it because we put the pills in front of her and she just grabs her water bottle. And, it's shocking how she's adapted. I will say to parents out there that are just starting, your kids will be way better at this than you will. It is amazing how our daughter's adapted to it. Her best friend in the world is one of the nurses she met in Mass General. So it's so we're tazemetostat's been great. Looks like MRI is showing that there's no more leptomeningeal spread. So it's a matter of just holding on and up to 2 years of tazemetostat, and we'll see from there. But yeah, we've kind of touched all of these different elements of it. It's funny, I see the questions and CAR-Ts thrown in there and stuff like that. And we've investigated all these different sort of, if this doesn't work, what's next? And Dr. Reddy's been part of that. But that's our journey.
Thanks for sharing. Thanks for sharing.
Yeah. Totally impressed by the parents. You guys are rock stars. I think that when you just brought up on one of those questions too, maybe this goes back to the panelists thinking about, what's on the horizon? What are some of the most promising new treatments that are coming that you're thinking about or working on?
And that might be to Dr. Raabe, actually.
Yeah, Dr. Raabe, do you want to talk about some of the preclinical stuff?
Sure, thank you. I think that the tazemetostat should be considered kind of like the first in class, like the Model T automobile for these type of therapies. So there are new, better tazemetostats coming along as well that might have less pill burden, might have better brain penetration. So once people start seeing that there's a signal in certain tumors, other drug companies will try to improve on the delivery or improve on the bioavailability, meaning how well it's absorbed. So that's exciting to think about. Of course, we think that there might be a signal in ATRT. Will it work for all patients? That kind of stuff will hopefully be answered by the next CRG clinical trial. And then in the meantime, what other sort of more targeted therapies can we come up with that would be not toxic to patients? And so we spend a lot of time in our lab kind of thinking about that and developing drugs that are good for different subtypes potentially of ATRT. And there's a lot of interest throughout the world actually in this. And as part of PNOC, we've assembled an international team that meets once a month through Zoom to present and share data that's not published. So this is something where we have people on from Australia and Europe. And throughout the United States, we have to pick a late in the evening Eastern time, which is very early in the morning the next day in Australia, for everyone to meet so that the people in California and Colorado and the East Coast and Europe and the Australians can all get together. So it's like 11 o'clock for poor Sabina to participate in Europe, but it's like 5 a.m. in Melbourne, Australia for those folks. So we can actually do this, and we have this great group that's bringing new ideas to the table and sharing. And that's going to, I think, really help move the field forward. So it's really a great thing that PNOC has. In our particular lab, we're focused on those MYC-driven ATRTs and are targeting mTOR. So we published a few papers on this, and there's some new, better mTOR targeting drugs that are coming along that are have shown real efficacy in adult glioblastoma. And so we think that we have some early signal that these drugs will be effective in ATRT, and figuring out how best to use them, put them together with traditional chemotherapy to make those work better with less side effects is what we spend a big part of our time doing in the lab.
Thank you so much. We have
one, maybe Rachel, just for Ashley, could you comment on sort of, there was one question about immunotherapy and where CAR T cell development stands for these tumors?
So I mentioned earlier, so there's a group in Seattle that is working on a B7H3 CAR T cell. Again, because B7H3 is expressed, we know that it's expressed on ATRT cells on the cell surface. There's some other groups who are also looking at other B7H3 CAR T cells. So I think that that's an interesting way to go. And like I said, that there is a study open in Seattle. There might be more to come in the future. I saw another one on immune checkpoint inhibition. I think there was a couple that were coming through. So maybe we could just touch on that really quickly. As far as nivolumab and ipilimumab. So people were asking about that. And there was some preclinical data suggesting that these drugs could be effective, and we're not sure if it's going to be subgroup specific or not. There is a study that is coming out of Dana-Farber that many of us will be participating in. It's going to be run by Dr. Chi, again, who's sorry that she can't be here today. And as far as using them off-label, or I should say not in a study setting, I think sometimes we do that, and when patients have multiply relapsed, we don't usually like to do that because we won't know the toxicities, and we like to do things in a more controlled setting. So I would say if you're asking if people do it in a non-study setting, sure, some people might, but hopefully we'll have a study open soon. And so it will be more available to people, and we can do it in a more controlled environment. But that's definitely something that we're looking at for our patients.
Thank you, Dr. Margol. Alyssa, Dr. Reddy, I'd like to ask this question to you, if you don't mind. There's a few questions about whether or not germline mutations increase your risk of poor outcomes. Could you answer that, Dr. Reddy?
Yeah, I think in general, we think that it does. On the 333 trial, there were only 10 patients that had germline mutations. That may have been in part because we know that children with germline mutations are at higher risk to develop rhabdoid tumors elsewhere. As Dr. Margol mentioned, there's a rhabdoid predisposition syndrome, so patients can have rhabdoid tumors in their kidneys or other. That's the second most common site, or other areas of their body. And the 333, those patients with tumors outside the central nervous system are excluded. So that may have been partly why. But on our trial, those patients did do less well. Again, it was small numbers, so it didn't reach statistical significance. But I do think that in general, we feel like those patients, there are certainly long-term survivors with germline mutations, but in general, those patients are at higher risk, not only to have a relapse of their ATRT, but to develop rhabdoid tumors elsewhere in the body.
Great. We have a question about environmental reasons for ATRT. Would anybody on the panel like to respond to that?
I can just say that we have no data to support any sort of environmental toxin. I think these things, it's really hard, and we understand, and sometimes even with different brain tumors, there seems to be a cluster here or there. So those kind of questions come up, but there's never been any association that I'm aware of, and I must the other panelists disagree that this is environmentally caused or related.
I just want to jump in at this point with a time check. We are just past the top of our hour. I know there's a lot of questions. If any of our panelists have another 5 or 10 minutes to stay on, that'd be appreciated. If you don't, we completely understand, you've got incredibly busy schedules. I've got a question here really regarding treatment protocol. And the question comes from Charlene or Shalina. My son had a full resection and completed ACNS 03333 in late March. He is slated to start proton radiation in May to target the tumor bed. Is proton radiation generally a recommendation when there is no evidence of tumor to treat? We trust our medical team and their recommendations. This is a question about the overall recommendation of proton focal radiation if there is no evidence of tumor after resection. I think that's a good question.
Yeah, I'll take that if that's okay. I think any of us could answer that. So we definitely feel like radiation increases the patient's chances of survival. We do know that some groups have taken the approach of sort of delaying radiation, but again, it's sort of a smaller series, and there may be patients that's possible. But the problem is we don't know who those patients are. And I do know, and it's actually in the 333 published paper, but of families that decided not to do radiation, they all had relapse on the study. It was a handful of patients, but I think as far as a community, for most patients, and Bruce, how old did you say this child was?
Actually, I don't have an age actually on this question.
Well, unless the child is extremely young and below the ages that the radiation oncology committee from COG, recommended radiation, we are not at the point yet where we are saying that it's okay not to do radiation. So I think we would definitely recommend that this patient have the appropriate radiation, even with no tumor there, because the chances of it coming back are very, very high.
Actually, it's come through 2.5 years of age.
We would recommend appropriate radiation.
Yeah, so here's a question. Could we see Dr. Raabe's MYC subgroup information?
Got a request for that.
Sure. I don't know if you all have the slides that we sent. If someone from PNOC Foundation could pull up that last slide that was part of the slide deck. If not, I mean, basically, like, I'm happy to have a separate PNOC Foundation thing to talk about all the preclinical stuff we're doing. I don't want to take up too much time with this, but I think the paper is published in Neuro-Oncology, which is considered one of the better brain tumor journals in the world. And so what we were testing is a brain penetrant mTOR inhibitor, and we found that ATRT primarily, actually, the primary tumors express a lot, not just of the two different flavors of this mTOR. And there are new classes of drugs that block both flavors, so both types of mTOR. And so we found that drugs that can do that actually work together, called synergize very nicely with traditional chemotherapy called cisplatin, leading to increased survival. So in a way of like making the tumor more susceptible to the standard chemotherapy that we use as part of the 033 protocol. So, so that's sort of in a nutshell some of our data, and we're continuing to kind of expand on that further to build that out and to make it a little bit better. So here's our slide deck. Thank you. Apologies, I didn't have that completely ready for you, but if you go to the very last slide of that slide deck, that should potentially have the sort of Kaplan-Meier survival curve, which, and if not, I've more or less done that justice, so we can move on to the next questions if you like. And Ms. Claywell, I'm happy to chat with you separately.
There's one common question, sorry, Ellen, that we get a lot. Is there anything in terms of dietary recommendations you have, especially, ketogenic diet? I'm sure you're being asked this question a lot as well. Maybe you could comment for everyone on the call.
We wish, I tell families this all the time, like I so wish that the answer was yes, because that would be such a great way for us to be able to treat this disease without the side effects of the therapies that we have to give. I usually tell families you should do a diet that you feel comfortable with, and eating fruits and vegetables rather than processed foods is good for anybody. But with regards to like cold, hard data that suggests that something like ketogenic diet is beneficial, we just don't have those data. So it's really hard for us to recommend something like that. But I think most physicians nowadays are used to discussing these types of things. So you should definitely talk to your physician and your team about. I think most people are really supportive of parents trying different things, but I wish we had cold data that, hard data that said absolutely, because we would love to be able to recommend a dietary modification. I do think it might be nice. I know the slide just popped up, so I'm wondering if people are going to have questions about the slide that was just on the screen, which was a little bit just about our upcoming idea for our PNOC trial. Do you think that might be something we should just go over since it was on the screen? Or I know we're running out of time, but it might just be interesting for people to see kind of what we're doing as a group and what our thoughts are.
I was trying to find Dr. Raabe's slides, so I put it up mistakenly, but perhaps you could do it.
Sure. So I think
I can actually share it, Ashley, because I have it right here. If that works. That's right. So yeah, let me go to share screen.
So I think, you know, I kind of in general, when we talk about ATRT, I think everyone's had such fantastic questions. And, you know, one thing I always feel terrible about when we have conversations like this with parents is just not being able to give you guys more information, right? So I wish that we could say, yes, it's imperative that we do subtyping up front because we know that this particular subtype is going to respond to this therapy. And we know that patients with, you know, this clinical phenotype, whether it's extent of disease or extent of resection, we know that those patients are going to do better or worse, or they need this therapy or that. But you've heard us, most of us, say to a lot of the questions that you've answered, like, we just don't have enough information at this point to give you a definitive answer. And I know just kind of scrolling through the chat that that's probably responses that you guys have gotten before, and it's frustrating. And like I said at the beginning, it's really frustrating for us too. So please know that we're in this with you. But these are kind of the issues that we face, which is we just don't have enough data. These tumors are rare. It takes a long time to do clinical trials. And again, on 0333, there are 65 patients. And we know that that's not all the patients in the country, and certainly not all the patients in the world diagnosed with ATRT, and we're just simply not capturing them because they're choosing not to go on a clinical trial, or they just don't have access to it. And so we're really trying to kind of fix that issue. And like Dr. Reddy pointed out, even, you know, at the end of ACNS 0333, it wasn't powered to do this, but we still don't know. We don't know if patients with metastatic disease need more intensive therapy or not. We don't know if extent of resection is important or not. And we're starting to get a hint that molecular subgroup matters. But again, we really don't have the data to say definitively, you know, which subgroup is going to be associated with what types of outcomes. So you can keep going. So we as a group, again, we have this really nice working group that consists of clinicians around the country and around the world with a specific focus in ATRT. And then Dr. Raabe leads our preclinical group, people from all over the country. And it's really fun because we just get to have open dialogue and share data in a really collaborative space. And so we've thought long and hard about how we could really change the field. And so these are our hypotheses and things that we really are looking to interrogate. So we think that, you know, analyzing genetic and biologic features is going to allow us to get to the point where we can actually risk stratify patients and hopefully identify patients that might need more intensive therapy or molecularly targeted therapy. And perhaps, like Dr. Reddy alluded to before, there might be this group that doesn't need such intense therapy. And we really want to make sure that we can pick out that group as well to kind of avoid some of those late effects, if at all possible. And we really want to make a database. So we work really closely with CBTN, who is great at kind of housing tumor samples and nucleic acids, so DNA and RNA from these tumors. And it's a shared platform, so anybody can go into CBTN and get the data. So it's, again, really collaborative and trying to just allow for a larger community of people to really study this disease. And then we're hoping that if we are able to gather all of this data, and we've got more than 65 patients to look at, and we really have this comprehensive database of clinical and molecular features, that we are going to be able to answer some of these questions, so that if we do this again in a few years, we have better answers for you, and we're not saying, well, we're really not sure. So I think the last slide has so this is what we've kind of come up with as a group, and the way that we think we're going to be able to learn the most about this disease. And it's coming up with a trial that is essentially part registry trial, and then part allows us to kind of assemble an expert panel for treatment recommendation. So I'll just go through this quickly. Again, I know we're short or we're over time, but we have designed a study that allows patients to enroll at any time. So whether you have a child who's newly diagnosed, they're in the middle of their, induction therapy, they've completed therapy, they've relapsed, whatever it is, we have a space for you to enroll your child on this study. We will do the molecular analysis for the site. So if your home institution doesn't routinely do molecular subtyping, then we will take care of that for you. And those results will be provided to the physician and to the family so that you do have that if you want it. And then we really think that kind of the upfront therapy, they're all good, right? So we know that the Dana-Farber regimen or ACNS 0333, they're effective regimens. And so we think that it makes sense for that decision to be made between the family and the treating physician. And then we'll continue to follow patients and collect the data. So we'll collect the data so we know, how kids are doing in 5 years, what was their response to radiation therapy, et cetera, et cetera. And in the event that a patient were to relapse, we would have all of their data already. And so we would convene what we would call like a tumor board or kind of an expert panel. And we would sit down as a group and review the case from beginning to current time, including the molecular data, the imaging data, et cetera, and take a look and see what options were out there for treatment. So as we've kind of alluded to, there's a lot of options. There's tazemetostat, there's MAMET protocol, there's B7H3 CARs, there's 8H9, all of these things. And we would sit down and look at those things. And based on the patient's characteristics and the knowledge that we have at that time, we would come up with some treatment recommendations. So we might say, we think these 3 are really good options for the family to consider. Or we might say, we really feel if we have new data at the time that this one particular study makes a lot of sense. And that's optional. So families could opt in or out of that if they wanted to. But essentially, we would have this very large database of patients and their molecular findings so we could actually interrogate it and learn something. And we would be doing it in real time. So we would constantly be analyzing these data. And if we found something, let's say we discover a group 6 months in where we say, oh my goodness, all of the sonic hedgehog patients that had a gross total resection and had no metastatic disease, they all did really well. We think that's important information for the community to know at the time. So then we could let everybody know, hey, we found this really small group of patients that did really well. We need to, consider treating them a little bit differently. So that's it's all of us trying to kind of come up with the best way to move this field forward. I think the other piece to that is also, obviously we work really closely with Dr. Raabe and the preclinical group. So at any time he and his group have something that we can move forward, we can easily say in that little expert panel at the bottom, say, you know what, we've got this study that we're running through PNOC. We think that your child would be a good candidate. And so kind of slot them into that study. So sorry, I went through that really quickly, but I think it's important that everybody knows kind of what we're all thinking. And I know everybody wants us to move the field forward. And that's kind of what we've come up with the best way to do it at this point.
Yeah, I mean, look, I just want to take the opportunity to thank all of our panelists for participating this morning. As a parent patient who was involuntarily inducted into this space 11 years ago, I can tell you that, what I'm most excited about right now is just the depth and breadth of PNOC's collaborative approach for people who are fairly newly inducted into this space. This is very unique. The real open source collaboration and partnership that's happening between doctors, scientists, researchers, and the way that's being done and the speed at which it's being done is really, really unique. And it's something to be excited about. There's more understood in the last 5 years about the biology of these tumors than probably the last 50 years combined. And now, the focus is obviously in translating those discoveries into translational therapies or combination of therapies that can really move the outcomes for these kids forward. So we're extremely grateful for all of the work that you all get up and do every day. And without that, the needle wouldn't be moved at all. So we also want to thank the other foundations that have supported the work of PNOC and continue to support the work of PNOC. And it's really only through this collaborative approach of working together both on the medical and science side and really the funding side, that we're going to continue to really make a difference here. I want to also thank everybody who's joined us today. We hope that you found this information helpful. If we didn't get to all of the questions, we'll do our best to actually answer them in a follow-up. Today's session actually has been recorded, and there'll be a link to the recording sent out to participants. And we look forward to having more of these in the future as we've got material information and updates to share. So thanks again, everybody, for joining. Wonderful to have your participation, and enjoy the rest of your weekends.
Yes, I'll just quickly add too, if you'd like to learn more about these clinical trials and more about PNOC, go to pnoc.us. And if you'd like to learn more about supporting their causes, go to pnocfoundation.org. Thank you very much. Thank you to patient families too for being here today.
Thanks, everyone.
Bye.
Thanks, everyone.
Thank you, Robert.
Bye.
Bye.
Thank you, Kate and Matt.